Hello, it's my pleasure today to introduce to you Dr. Ian Campbell and his wife Alison, who've been with us here in Toronto for 3 days, and we have been talking about integrated mission. And we want to share a little bit about that today. And so I'm going to pass over to Alison, who's going to introduce the first subject.
Well, I think for me, integrated mission has to do with experience and practice more than with theory. And so I'm going to ask Ian to share first something about the experience that got him started thinking about integrated mission.
Well, I'm a doctor, and I don't normally introduce myself in that way, but I'm remembering that part of my identity back in Zambia, where I worked in a Salvation Army hospital, Chikunkata Hospital, from 1983 to the end of 1989. And a very surprising thing happened in the world of medicine and health during those years. Something unexpected came that tested health systems to the limit, and it still does, and that's the epidemic of HIV and AIDS. Now, people in the Western world often think that this is beaten now because treatment is apparently available out there to people, but the big thing to know today is that as more workable treatments, not cure, but treatments become available, so the prevention dynamic is dissipating. There's less focus on it. But I want to go back to that early experience of encountering HIV in the 1980s, which got us on a pathway towards integrating faith and practice in, I think, what felt to be new ways, especially in relation to health.
Okay. So when did you first meet HIV and what happened?
What happened is that in the 1984s, we started to see people who were responding differently to tuberculosis treatment. They just didn't get better. They looked different, they presented differently, and then by 1986, we began to recognize something that was historic. It was the onset of the pandemic of HIV affecting sub-Saharan Africa in a mammoth way, in a way that we realized would affect future generations irreversibly. So health systems were tested, mission health systems people were tested to realize that this was beyond our grasp. We could not handle this but in normative hospital-based ways. Already in those years, there'd been an enormous tradition of engagement and outreach in community through other issues, particularly leprosy. So the big learning ground that enabled us to move rapidly on HIV toward integrating family, community, practice, culture, faith, as well as support by health systems, was the precedent of engagement in helping to reintegrate people with leprosy, burned out leprosy, treated leprosy, back into their home setting. So with that as the precursor, I recognized, along with Zambian staff, that the way forward was not going to be to fix this up by commodities. It had to be engaged with by communities. And so with that realization, we felt that the link from the bedside, the institution, if you like, to the living space of people was going to be the key strategic way forward. It was the only way to get the quality of engagement and care, and it was the only way to get attention to prevention as well, because of the fact that the numbers that we all look for could be, if you like, engaged in, attracted, in a way developed by the community around taking on this issue for themselves in a way that embraced them in the world of preventing for future generations.
Can I give an illustration
Yeah,
of that?
please.
Now, I came into the story a few years later as a research assistant to the team that was visiting in the communities. And what I saw was that when someone found they had HIV or was told a diagnosis of HIV, the team would ask if they were happy to have a visit at home. And the team would visit them at home so that the family entered into the conversation about what is this problem, what do we do about it, how do we live together. And what we learned very quickly was that if that conversation would happen in the home with the family, the situation would normalize very quickly. Though the family would have reactions and have to talk through what happened, how did this happen, and all that discussion would happen, there might be anger, there might be frustration or great sorrow expressed, but the family would pull together. And we saw that if we went home, the family would pull together. If we didn't go home, the family might not pull together, the marriage might break, all kinds of problems would come up. And that's actually the story that was happening around the world at that time in the late 80s. HIV equals conflict equals family problems. But we were finding something quite different going on if we accompanied people home. The second thing I saw was that if we visited a few families in a neighborhood, the neighborhood would become aware that when people are sick with this new disease, we don't have to be afraid. This is a huge change in a whole neighborhood because of a caring interaction with the family. And we didn't know at this time of the politics around HIV that were raging in the rest of the world. We just did a natural caring, believing that the family could pull together, and then when we saw the community react, we stepped into conversation with people without pointing fingers at who might have HIV, but discussing with the community, what is the shared concern that we have here? How can we as a community live with this new challenge that's facing us? I'm a community development person, and what I learned was that communities can be poor and can pull together and can show amazing responses when faced with a new challenge, as long as there's somebody there for a conversation and to help it happen. So the other thing I learned was that all of this was happening in a very strong faith-based environment. And all these things seemed to come together where people would call on God's help and would see God's help in working out a conflict, in resolving, and in also finding a way forward with a new challenge.
I'm going to put a bit of a timeline on that, historical markers, if you like, because we were in the centre of history, unbeknownst to us.
Yeah.
We were the first to develop what was called a home-based care and prevention approach, where home-based care was done by a team, as you say. Let me just give you some figures. Like 86, 87, 88, there was a logarithmic progression of people dying in hospitals and home. Huge chaos reigning. But at the same time, by in sync with that, at the very beginning, engaging with the notion of ownership by people in their home, in their family, in their neighborhood community, to take charge of their lives, to look to the future, which they felt anyway. They felt it dissipating, but they could look to the future. And they could really read the future better than any outsider could. Longitudinal memory. That's the nature of community in relational societies like Sub-Saharan Africa, South Asia, China, wherever, in contrast to a lot of what we understand to be Western cultural dynamics. Although it's there, embedded somewhere deep down. What we found was that it became completely appropriate after a year of engaging with home care to be able to see that behaviour change could be an open agenda, but not, I was really personally very careful with the articulation of this because we didn't want to be seen as imposing behaviour change from the pulpit or anything like that. It had to instead be given a year of time for us to learn, with our Zambian teammates mostly, that community determined, neighbourhood determined and chosen behaviour change was the way to go. But how to stimulate that? Well, just to give an image, as the numbers increased of more, people sick and people dying, so the numbers of people responding in sync with that began to increase logarithmically. You care with a person in their home environment, supported by an institutional setting, and you will see the change in the community. The biblical image, of course, that comes to mind is the river of life. Get into that stream, and the waters will carry you through, and everybody will be gathered up into that. Streams of living water. So it was no surprise to, what was no big thing for us in a sense, as we moved from that Zambian environment, as I moved to the international headquarters role of international health services, which was known then as the medical advisory role, quickly changed after a few years to health services and facilitation of responses and all that kind of different paradigm. It was no big thing for me to see on day one of entering IHQ, just before you came, John, that our mandate, our mission, our task, our challenge was to go global with this paradigm. It wasn't going to be sufficient to just do medical fix-ups in different parts of the world to try to keep, fragile hospitals alive, whether in India or in Canada or wherever. Sometimes these hospitals don't look fragile, but we do know that internally there are fragilities of all kinds, whatever our economic background as a country or the cultural background or the history. We're in a commercial world, and it's a tough thing to keep health systems alive. So how did we feel it could be done? We saw that by learning from our experience that was growing of engaging with the AIDS epidemic, there was a potential here for stimulating an intercultural transfer of concepts around the practice grounds of care with the person, accompany the community, stimulate their response by what was termed then a community counseling approach, and find in the middle of that, in the middle of the experience of accompaniment, of team life with people, building and budding off other teams in other layers, but essentially in a learning and sharing mode together, it was possible to see that these were expressions of enlivening our own faith. These were pathways in which our own sense of mission was enhanced. And we began to see, before certainly I left Zambia in 1989, that our sense of mission was not so much about a task to be done with people and then wrapped up, but it was to be a participant. It was to be participants together in people's life journey, so that their story would dominate, not mine, not ours, not the team's. It was about their story being respected so much that the relational link could sharpen up and become healthy, so that arising from that was a surprising array of invitations to go further into people's space, into their lives, into their story. And it's that combination of accompaniment, of participation, of listening to story, of group-based relational counseling, of seeing that transfer from one to another could take place. In other words, the budding of movement was happening. A health-related and faith-linked, faith-inspired movement was happening before our very eyes. We saw the numbers grow, in other words, but we saw it happening because there was a foundation of quality. And I think that's the experience that I took in February 1990 with me to IHQ, into this international role. So, it was a quick thing for me to see that there was a way to work interculturally, not so much through, bringing interventions of a systems kind, but to stimulate the strength that people had to make a response. What we had picked up by then, I have to say, was that the 4 core strengths that were working for people in this Zambian experience and the Sub-Saharan African experience could also work elsewhere. And those 4 core strengths had been articulated by then as care by being with, by presence. Community, not so much as organization, but as belonging. This longing for belonging was surfacing. Change, the potential for change, the capacity for change not imposed, but change stirred, so that the ownership of change could be local and the support to change could be the role from the system. And of course the other strength that embedded the global approach, in the next, until now, from 1990 onwards, was that underpinning of hope. So these are the core strengths that led us to an appreciative inquiry approach, that led us to a conversational approach, that led us to the realization that institutional systems needed to face the challenge of adapting to their strength. So, that combination of local response through conversational, relational engagement, synergy of home and neighborhood, critically important, yet the other dimension of the response is the response of the system, the organization, the Salvation Army, the church, to adapt itself into the life of the other constantly, and to reflect that adaptation in the way we do our organizational stuff every day.
Well, we're going to come back in a minute to think about what happened next.
Okay.
Super.